Hi, everyone. Welcome. We are going to go ahead and get started. My name is Caitlin Neese, and we are super excited for this webinar tonight. On behalf of Tactile Medical, I want to thank each and every one of you for joining us this evening. We are thrilled to have 2 SLPs and 1 social worker with us tonight. So I am going to go ahead and introduce our panelists. First off, we have Erin Collada, who is an SLP, and she is also in the process of getting her CLT to help head and neck cancer patients. We also have Julia Porter, who is an SLP and a CLT. And we have Amber Peck, who is a social worker within the oncology space. So tonight we are going to discuss head and neck cancer patients and a patient's mental health journey from diagnosis to survivorship. As you all know, every clinician plays a role, and our hope is that we can all learn tonight what else we can be doing for these patients to really improve their quality of life. One thing I will note, if you do have any questions during the webinar for our panelists, if you could please add those in the chat, and we will try our best to get to those at the end. So starting off, we have Erin, and she is going to share some details around mental health challenges that head and neck cancer patients often face, as well as some statistics on lymphedema.
Good evening. As Caitlin said, my name is Erin Collada. I'm a speech pathologist, and I've been practicing about 15 years. I've been working specifically with the head and neck population for about 13 years. And during that time frame, standards of practice and practice patterns have changed quite a bit, as have topics often looked at in the research publications. I just wanted to highlight a couple things to do with mental health, and basically just that our head and neck population has several unique risk factors for developing psychosocial comorbidities and just mental health challenges associated with the diagnosis and the treatment of head and neck cancer. Many of them experience depression. It is underreported, and there's also many issues relevant to access to mental health and treatment of lymphedema. I'm just going to jump down specifically to number 4 on the slide here, as that kind of really drives home the issue related to mental health, and just that head and neck cancer survivors have 4 times the rate, 4 times the rate of death by suicide compared to the overall cancer population. And that's really pretty staggering if you think about that.
Thank you so much for sharing those statistics, Erin. So next we're going to have Julia, who is going to take us through her journey as a patient, as well as her care pathway as a clinician.
Hi, my name is Julia. To get a little more personal here, I have been a speech pathologist for 8 years, and 2 years or so into my professional career, I was diagnosed with stage 3 adenoid cystic carcinoma, which is a rare type of salivary gland cancer, which was discovered after surgery to remove what was thought to be a benign polyp in my nose. And so this kind of completely out of nowhere diagnosis was followed by 2 more surgeries and chemoradiation. And I think really for me personally, that moment that I heard the words, "you have cancer," really just solidified a distinct difference in my life, or a time point in my life where it became kind of before cancer diagnosis and then everything after cancer diagnosis. And I think what was probably the most surprising thing to me as a patient, and not necessarily, or no longer as a provider, was that difficulty in adjusting to life after I was done with cancer treatment. I kind of went from being told where to be, when to be there. This is the day of your surgery. Too bad if you had anything planned that day or for the next 7 days after. This is the day of your follow-up visit. This is when you start radiation, and you're going to be doing that for the next 6 weeks. You kind of go from that to, okay, back to life. You ring a bell maybe twice if you did chemo and radiation. And I think, I was really surprised at that that difficulty with adjusting to at 26, especially kind of that what now. There are more visits and appointments and scans and things like that, but that was a really big challenge for me. And I was very blessed to have a medical team that proactively recognized that, even without me necessarily saying so, and referring me to mental health services. And so now, as I think about what my patients need, kind of what the head and neck survivor needs, I think about kind of where they're at in their cancer journey and try to anticipate what might be needed and when. So for on the next slide, I have an example here of what a kind of potential care pathway may look like for the head and neck cancer patient. And I think it's important to note that this concept of survivorship really begins at the time of diagnosis. And that term survivorship really refers to the broad experience of the cancer patient on the cancer continuum, meaning those who are living with, through, and beyond cancer. So again, it's generally accepted that survivorship begins at the time of diagnosis. But it is important to note that survivorship, or that term, can be used differently, kind of depending maybe on specific program needs, or maybe facility specific programs. But regardless, care needs, including rehab care, can look different depending on where a patient is at on their survivorship journey. So for the head and neck patient, at diagnosis, we might be engaging in more of what's called prospective care. So we are looking or screening for things that we might anticipate that a patient needs, simply based upon the diagnosis or the ultimate intervention plan, whether that be surgery, radiation, chemoradiation, a combination of all three. And at the minimum, this should include referral to a speech language pathologist, to nutrition, screening for potential lymphatic risk or lymphatic dysfunction risk, such as plans for a neck dissection or the field of radiation. Does that involve the neck nodes, one side, both sides of the neck? And maybe looking at performance status. Does the patient need to get in to see a physical therapist to address, potential functional decline as a result of their treatment sooner rather than later? Screening for psychosocial needs. And all of this should happen pretty soon after diagnosis and as that cancer treatment plan is being determined. As a patient moves through their treatment, some of these same services might begin to look more like supportive care. And again, it's important to note that patients might need different services at different times, but what they need is going to depend on where they're at, or the focus of the efforts may change, even if it's the same service. As a patient moves out of that kind of more acute phase of treatment, we might be looking more at rehabbing what functional impairments have resulted as a result of their treatment. So maybe there is cancer treatment related fatigue that's persisting, or maybe that post-radiation lymphedema is starting to emerge. And if a patient's not already in rehab care at that time, or getting any of these services, or maybe they don't need it yet, we still have the opportunity to screen for these services as a patient moves into surveillance, meaning that they may not be receiving active treatment, but maybe they are doing routine imaging, office visits, clinical exams, lab tests. And this time frame offers a good opportunity to be systematically screening for potential supportive care needs. And in general, early identification of these needs is best, including for things like lymphedema. But it's important to note that it's also never too late to start. And I would say that in most, if not all cases, late is better than never. As I mentioned, early identification is the hallmark of any supportive care model. So supportive care services could, like I said, pertain to rehab services, pain management, palliative care, lymphedema services, psychosocial care. But in a more integrated model, these services are going to be screened for more routinely and systematically. In a more siloed, fragmented model on the left side of the screen here, It's really under the direction of each or one provider often to identify and determine referrals for these other services. However, in a more supportive care integrated model, patients are being screened for these services at routine times. Providers are talking to one another in consistent communication on a multidisciplinary level. Of course, there's challenges to implementing something like this, but in general, we know that supportive care services, even if specific models, in execution aren't often available in the literature, especially as it pertains to head and neck. We know that these services can be really beneficial. They can improve quality of life. They can decrease mortality. They can result in better utilization of healthcare services, especially at end of life. And so all of these kind of key points can be good talking points for key stakeholders when if you're trying to kind of implement something along these lines at your own facility. And as I mentioned, routine screening for potential needs, whether that be lymphedema, rehab, swallowing therapy, things like that, can really be used or identified with the use of patient-reported outcome tools. And these tools really reflect or measure a patient's healthcare experience or status without like the bias of a clinician. So this is, filling out a questionnaire or a survey. And there's lots of different tools that are available in open access that can be used by any clinician. For example, one being the functional assessment of cancer treatment. There's a subtest specifically for head and neck. I would say the FACT, the PROMIS, and the MDASI, all of these actually represent a larger volume or a database of psychometrically valid assessments and can be used depending on your own clinic's population, disease site, or specific functional impairments you're trying to assess. And again, these ones on the left have some specific oncology rehab, maybe subtests to them, maybe a physical subtest or lymphedema subtest. And then we have some other supportive care tools on the right, some of which Amber will go into in a minute. But regardless of the tool that you're using or the way in which you're using it, it's really important to have that appropriate care cascade in place and that you're communicating with your team to discuss the things that you might uncover in your visit, even if it's not specifically related to your individual, professional skill set.
Thank you so much for sharing that, Julia. So as Julia just covered, really treating these patients does take a village, and it also takes an established multidisciplinary approach. So next we are going to hear from Amber. She's the social worker, and she is going to share her insight on how she works with other clinicians to really provide the best outcomes for these patients.
Hello, everyone. Again, my name is Amber Peck, and I'm a licensed clinical social worker, and I have worked in the hospice and oncology fields for over 20 years. I will be speaking directly about the distress thermometer and early intervention in social work, in the cancer journey and mental health supports to improve coping with a cancer diagnosis and moving forward into survivorship. As providers, how we play a role in increasing quality of life and emotional well-being is what drives us to be a more knowledgeable clinician. In the literature, and as noted by Erin and Julia already, patients with head and neck cancers have higher rates of emotional distress than any other cancer group. Types of emotional distress commonly experienced by those with head and neck cancers are depression, anxiety, post-traumatic stress disorder, and suicidal ideation. Compounding the emotional distress are the side effects and the physical changes resulting from treatment. Further compounding these issues already are the financial challenges such as medical care costs and changes in income, legal issues, access to care and transportation needs, spiritual and existential crises, and changes in their personal relationships. Truly, cancer touches every aspect of a patient's life. Effective assessment of distress is critical in caring for cancer patients. A well-known tool in the cancer world is the NCCN Distress Thermometer and Problem List. That is the National Comprehensive Care Network Distress Thermometer. If you look at this slide, you can see this is a simple yet revealing tool that encompasses the critical domains of a patient's life that can be affected by cancer. It is relatable and easy for patients to understand and rate their level of distress. On the left side, you see that a patient can rate their stress from a 0, indicating no or low distress, to a 10, indicating high distress. There is no right or wrong answer. Purely, it's the patient's perspective, and this should be completed by the patient only. To the right is the problem list, which helps clarify and provide specific psychosocial concerns that may be contributing to their score. Sometimes a patient cannot conceptualize a number for their distress. So the problem list can really help with that. It allows the patient to identify other needs in addition to their cancer diagnosis that they are facing. The simplicity of this tool makes it patient-friendly and allows the cancer team to have a better understanding of needs and concerns and can refer out as appropriate. This is how the distress thermometer is used in my clinic. It is given to a new cancer patient along with the other new patient paperwork to complete prior to seeing their oncologist. The medical assistant collects the paperwork, which will include the distress thermometer. If the score is 0 to 3, then social work intervention may not be necessary, but the social worker will review at a later time and follow up as appropriate. If the score is 4 to 7, the social worker will follow up with the patient in clinic if possible, or within 5 business days to address the identified needs. A score of 8 to 10, that's significant for high distress. Social work will be notified promptly and will follow up during clinic time or make arrangements with the patient for follow-up. The distress thermometer provides the medical team the patient's perspective and current life stressors. An example, in our breast clinic, the doctor actually collects and reviews the distress thermometer at the beginning of her consultation to help her have a better understanding where her patient is emotionally. The doctor will hand the distress thermometer back to me, and she may make a comment. The patient says she scores a 3, but her reaction was more like a 10. I took more time to make sure she understood her plan of care and next steps. As the rest of the team, myself and the nurse navigator, we will also be aware of, the level of her distress. The extra time is reassuring to patients and they feel heard. Then the distress thermometer is scanned into the electronic medical record for future records to monitor baseline. As an oncology social worker, I use the distress score and problem checklist to identify along with the patient to address next steps to address their identified needs. And I may refer to support groups. My lights just switched off. Sorry. I may refer to support groups. I may refer to myself for supportive counseling, refer to clinical psychology. I may refer out to financial resources such as Medicaid or other financial assistance programs, referrals to local community resources, etc. This engagement at the beginning with the patient lessens distress by knowing the availability of support, if not needed now, but it might be available in the future and they are aware of this. This also encourages empowerment to be more open about their needs and an awareness of support and potential resources for those needs. The distress thermometer is very useful throughout the cancer journey, particularly at strategic times, such as the initial diagnosis, which again can provide a baseline of emotional well-being and other stressors at the time of diagnosis. Another option is the significant changes, such as adding an unexpected treatment or surgery that was not anticipated previously. Another time to provide the distress thermometer is for cancer reoccurrence. And lastly, survivorship. Identifying and addressing coping needs as well as psychosocial stressors early and along the cancer journey, research is showing there is improvement in mental health and resiliency post-treatment for cancer patients. A little about my role as the oncology social worker here in my cancer center. And I'm sorry that my lights turned out. If I don't move, they shut off automatically. I have been the only social worker for about 50 providers for the last 3 years. We opened in January of 2020 and then COVID hit. Though I'm available to all patients here, the majority of the patients I see are breast cancer patients. Our breast cancer clinic runs in a true multidisciplinary format and utilizes the distress thermometer as I outlined earlier. I'm involved with head and neck cancer, but typically not in the beginning of their cancer journey, but during later on in their process. Due to my being the only social worker these past 3 years, there was a limit to my capacity. Head and neck cancers have been identified as the next clinic here to be a full multidisciplinary clinic and will fully utilize the distress thermometer. Both breast and head and neck cancers have similar emotional distress needs due to treatment options, which can affect appearances and quality of life issues such as lymphedema. Recently, we did hire a social worker, and I'm grateful that I'm going to have support and knowing that we will have more capacity to reach more patients and have more effect with patients having that multidisciplinary approach. Here at my cancer center, we are connected to a hospital, so we have the ability to use the emergency department for any concerns for suicidal ideation or active plan. We can escort the patient to the emergency department for a behavioral health evaluation, develop a safety plan, which could include hospitalization and or outpatient follow-up. For those with mild and moderate distress, getting patients seen by a mental health provider, as you know, since COVID, can take months. But utilizing support groups, whether in person or virtual, is helpful. We provide here at my cancer center a SPONC affiliated support group, which is primarily ran by our dietitian and Julie and Aaron, which are our speech language pathologists. This group is awesome. Group members empathize with each other. They provide support, solutions, and hope. Their connection with each other is amazing. SPONC, which is the support for people with oral and head and neck cancer, is a wonderful organization to help address the unique needs of our patients. We do have a psychologist here on staff, but she is not in the actual center, and there is a waiting list of a couple of months to be seen. Currently, we have a PhD clinical health psychology student that is available for about 6 to 8 sessions. Social work is available for supportive counseling, for adjustment to the new cancer diagnosis, for crisis and grief support. In addition to, we are available for other psychosocial needs, such as referrals for resources. Having these avenues for the patient early on helps decrease the significant distress and hopefully leads to better outcomes in survivorship.
Thank you so much for all of this information, Amber. So now we're going to have Erin come on, and she is going to touch on rehabilitation care and more on her role as an SLP in her cancer center.
Thanks, guys. So I think in general, a couple of things we really wanted to touch on is just that as rehab clinicians, regardless of our specialty or regardless of discipline or any specialty certifications, we can and do play a big role in outcomes and in treatment and access to treatment as far as mental health and lymphedema. I think the biggest thing we can do is just make sure we're educated about the multiple ways that we do impact this care with these patients. Something that I believe is really important for us to understand is that as we are present for very critical moments in survivorship, for example, patients are educated about the concepts of radiation and lymphedema, and that they're lifelong and progressive and non-reversible. That is first truly salient to somebody when they are really beginning to understand their issues swallowing or their trouble chewing or speaking or mouth opening or whatever it is. And just that they've come all this way, their cancer is likely cured, and now they have these functional changes that are lifelong. Then to get a little more specific about lymphedema and me as an SLP, I think there's multiple ways that we can have an impact here. Whether we choose to pursue education or certification in lymphedema therapy or not, I like to discuss the fact that whether we feel that we are considered a primary lymphedema treater, I guess, rehabilitation specialist, since lymphedema is a functional impairment, we are treating it whether we're aware of it or not. So it's a bit of a call to action to educate ourselves and to rely on and stay in communication with our multidisciplinary team. Within the concept that lymphedema is a functional impairment, it's a functional impairment of the head and neck. And we are the rehabilitation specialists when it comes to communication and swallowing. And being that is true, you're stimulating the lymphatics, whether or not we were aware of it. So as I slowly came to have this realization years ago, I began to understand that there's things that I don't understand and that I really need to dive in and educate myself. And then I'm actually going to talk about the advocacy piece on a future slide.
Thank you. So as we've learned thus far, we all play a role, but sometimes finding where you fit within a cancer center can be a challenge. So I'm going to ask both Julia and Erin to come on to just kind of walk us through your experience and your journey as an SLP and how you were able to kind of find where you fit within your cancer center.
Well, I'll start in just realizing that lymphedema is external and internal, and it is a functional impairment. And knowing there are things I don't know that I need to learn. I think relying on our team members and their expertise, and then also slowly beginning to feel empowered to be outspoken in the places where I can play a role. And that's changed quite a bit over time. That can change or be different. We can all fit in a little bit differently, just depending on who else is on our team.
Yeah, and I just wanted, to add. So I kind of along with Erin, I feel like I feel like Erin, you did first, and I was like, oh yeah, I totally see what you're talking about here. In terms of just recognizing that speech pathologists can be in this space. So I guess I'm speaking more as my role as a speech pathologist, but that we can absolutely be in this space, but we need to know, especially because we need to know kind of what our exercises are doing in terms of stimulating lymphatics and addressing the lymphatic system. I completed my CLT earlier this year, and it was probably the hardest thing I've ever done, I would say. And even before that, I attended like a conference down at MD Anderson. And in that conference, there was a session about head and neck lymphedema. And I was like, wow, learned a lot with that, but then realized, okay, there's so much more that I need to learn. And then even after getting my CLT, I feel like there's still more to learn specific to head and neck. I think that, it's a very under-recognized and under-treated body part in terms of lymphedema, despite the very disastrous effects that it can have on function. And so I think, as Erin said, really just communicating with our, we work with other CLTs as well. And so everybody kind of knowing what they're addressing and how. So for example, if there's something that some of these patients could benefit from 2-hour sessions. And so really communicating with our team to be like, okay, this is what you're addressing. This is what I'm going to address. Okay, this is what I saw in my visit. You're going to kind of work a little bit more on this part. And sometimes even timing up our visits where maybe they see the other lymphedema therapist first and me, and we can do some of our swallowing specific things after they've kind of gone through their initial manual image visit. So anyways, kind of off on a tangent there, but I think it's a long journey to find where you fit in this population. And I think also Erin and I get asked a lot, what all did you take or do to feel comfortable with this population? And again, I would say, despite the fact that we do have some additional certifications, there is so much reading and information out there to really dive deeper into, I guess, specifically lymphedema, but then also just generally radiation on fibrosis. What is radiation? What is chemotherapy? How is that affecting the body systems that you are working with? And having a sound foundation in that knowledge base can really support making good clinical decisions and supporting good outcomes for your patient.
So I've had the privilege of working with both Julia and Erin's patients, and I feel like I've definitely seen a change in their behavior over the past few years of just really feeling empowered and owning this patient population. And now they say, no, it does fit within our scope of practice. So I feel like this is a great transition. Maybe a few years ago, they wouldn't have been able to do this, but they are both going to educate us on the lymphatics of the head and neck cancer and the prevalence of lymphedema in this patient population.
Again, I won't be able to cover everything about lymphedema in the short time we have, but the lymphatic system is a very important body system. It has a lot of different functions, one of which is carrying fluid known as lymph throughout the body. And we know that a third of the body, or over a third of the body's lymph nodes, which is one of the structures of the lymphatic system, are located in the head and neck. And so tumors themselves, surgery, radiation can cause damage to these lymph nodes, vessels, and capillaries, and really affect the transport capacity of the system to be able to move that fluid along, or that protein-rich edema that can start to build up. Because it's not able to move as well, this leads to swelling, chronic inflammation, eventually fibrosis. And it's really, as Erin said earlier, leads to and is in and of itself a functional impairment. We know that lymphedema is present in a vast majority of head and neck survivors. And it's important to note that lymphedema can manifest itself in different ways. So beyond just kind of that classic turkey neck or turkey waddle term that providers sometimes use, there could be other more subtle signs of lymphedema. This can include dysphagia, changes in swallowing, can include feelings of discomfort, maybe tightness, restriction, having a reduced range of motion, even impacting breathing, voice changes in speaking. And so Tactile does have, and there are screeners available to kind of try to flesh out some of these more subtle symptoms that, again, may not be visible externally, but that can be captured with more in-depth questioning.
I'm just going to go into internal versus external lymphedema and the impact on swallowing a little bit further. Among head and neck patients, external lymphedema manifests as soft tissue swelling, while internal lymphedema affects the mucosal line structures of the aerodigestive tract. Both the presence of internal and external lymphedema is associated with greater patient perception of dysphagia, as well as presence of laryngeal penetration, aspiration, or diet modification. And it is at this point, pretty well accepted that treatment of lymphedema beginning as early as possible has positive impact on dysphagia-related outcomes with the population. I think another way that we can really play a role here regardless. So Julia talked about the education and just the innumerable hours of reading and education and everything that can go into this population, and really the fact that these functional impairments they're cross systems. I mean, you can't really pinpoint one specific pathophysiology or etiology. It's multiple systems at play. And because of that, we all on the team need to know what we're doing. One way I think that regardless of our knowledge base relevant to lymphedema or chemo and radiation, that we can advocate and improve or increase awareness is just in the language that we use. Many of us SLPs might regularly look at endoscopy or fluoroscopy, and we can just be more specific about some of the things that we see, naming arytenoid swelling or arytenoid edema or epiglottic edema, and even a brief statement about the impact that that has on the anatomy and the reservoirs per se within or around our larynx where residue can sit before or after a swallow, I suppose. Same thing with fluoroscopy, just commenting on edema or the size of the pharyngeal lumen and thinking about language that means something to us as well as to physicians. Another thing that crossed my mind just now about the role that we play relevant to mental health and psychosocial impact is simply validating many of the symptoms that these patients experience that are not visible to many people, because this larynx here on the screen could be inside a neck that looks completely normal on the outside, or a face or a chin. And the patients, they experience a wide range of symptoms, and it might be the tightness, the pain, the pressure, the fullness, the trouble breathing, and just, simply validating, yes, I believe you, I hear you. And those things are common with internal lymphedema, and giving them language to then go and maybe discuss with their doctor even further. So I think regardless of our training and knowledge base, we as SLPs can be empowered to participate in these ways, and also empower the patients to have the language or the vocabulary to ask their physicians, bring up symptoms. Hey, throw the speech therapist under the bus and say, hey, I was talking about this, this sensation I have of getting strangled every time I lie down, and the fact that I know I can breathe, but it feels like I can't breathe. Could that be internal lymphedema? And if so, is that something that you could document or diagnose me with? Because I believe we'll touch on here in a second, but just having that diagnosis makes a huge difference when it comes to insurance and coverage down the line.
And as Erin said, it's important for patients to know or be aware of the fact that lymphedema is really a chronic issue and progresses to fibrosis, especially if left unmanaged or untreated. And so it's important that patients are connected to care in clinic, whether that be with a lymphedema therapist, regardless of who that lymphedema therapist is. Maybe they are getting kind of the more traditional PT and OT, and then also swallowing therapy as well. But we want to make sure that patients are also able to manage this lifelong issue through daily home treatment as well, through compression, exercise, knowing to elevate when sleeping, and also being able to perform that self-MLD. However, that is pretty challenging for patients to perform on themselves, which is where potentially looking into something like a pneumatic compression pump can be helpful, like the FlexiTouch. Again, this is a great tool that can be used for home management. It does not take the place of a lymphedema therapist, but can help with kind of that transition to lifelong and home care, home management. And I would say, feedback Erin and I have gotten from patients tend to be that it's pretty comfortable to do. They might kick back just like the guy in the picture, kick their feet up for 32 minutes and do their daily treatment. Many of them, I think Erin has a good story about a patient who came back the next day and said he peed like a racehorse after his demo. So We have seen the effects that this can have on our patients. And again, keeping in mind that ultimately what we are trying to accomplish are what the patient wants to accomplish, which I would say in a vast majority of time is really maximizing their functional outcome, having a happy, healthy swallow, neck range of motion, neck function, shoulder function, for the rest of their lives, often in a case for treatment, especially in the case of a squamous cell carcinoma, a very treatable disease. So patients are being diagnosed younger, they're being cured at higher rates, and they're living longer. And so it's really important that we're addressing these potential long-term functional needs and the tools they might need to manage these long-term needs as early as possible.
Thank you so much to all of our panelists. So this does conclude our presentation portion of tonight's webinar. One thing that I did want to mention is we will have this recording posted on our homepage, which is tactilemedical.com. We hope to have it there early next week. And we also do have a myriad of other educational webinars just like this. So whether you want to check that out, or if you would also like to share this webinar with anybody in your cancer system or your hospital system, we would absolutely love that. So now I am going to go through the chat for some questions, and I'll ask our panelists to come back on to answer those. Okay, so the first one, any suggestions for SLPs to hold space for patients' frustration, distress within scope when not part of a cancer center?
I guess I have a question, which I'm just going to answer it both ways, but I didn't know if this was like just regarding their general distress and mental health and acceptance and how their life is different forever, which of course I feel like Julia might have a better perspective on this. But I would say if not in a cancer center, number one, the unfortunate first thing that I have to say is no, we're not all in a cancer center, but the level of care that we can provide is going to be the best if we are a team, regardless if we're all physically in the same place. But know the other providers, know who's on your team, know who's seeing the patients, know what they know, and just be able to maintain that conversation. If there isn't anybody else, recommend referrals. Recommend referral for mental health, for social work, for, whether or not that is social work as far as helping with resources or access to counseling. And I don't know if you guys have any other thoughts on that.
I have some thoughts. If the patient's being diagnosed initially and is suffering distress, it's a new diagnosis in a hospital setting, it would be the social work or discharge planner in the hospital setting. If you are not in that kind of setting and it's strictly outpatient with just speech, occupational and physical therapy, you can reach out to your local cancer resource center. It could be, I know this is all over the nation, but it could be whatever county you're in, cancer resources, and start there. And you can help give a patient a couple of community resources that can help take that distress and go and move forward with that. I hope that helps.
I was just going to say also just being familiar with, patient support networks and organizations like the Head and Neck Cancer Alliance or SPONC. Some of these resources have online platforms as well where patients can communicate, even if they're not like a Facebook user or something. There are some great community platforms available through those organizations. So Inspire is one through the Head and Neck Cancer Alliance, or the Head and Neck Cancer Alliance is affiliated with. And so potentially, at least for that patient or patients to connect with they may not, especially in a more rural area or something like that, they may not know anyone else who's been through kind of similar, something that they've also been through.
The second question is one I will try to take on. So they ask, any ideas of when or if Medicare will cover this pump? My patients really do love it, and they really do see a difference. So I'm so glad they are seeing a difference and they're loving it. So I feel with the promising update, just with passing of the Lymphedema Treatment Act, that hopefully, more insurances and Medicare will really recognize head and neck lymphedema, which hopefully then will trickle down to coverage of the FlexiTouch, which Tactile is, of course, working diligently on. So hopefully more to come on that one. And thank you for asking that question. So the third one here, I think, would be for the SLPs. And they asked any suggestions for a patient with severe internal lymphedema. He has a FlexiTouch, has been as severe as trach, still has a PEG. He's getting lymphedema management through an excellent OT CLT, but I am also doing effortful swallows and diaphragmatic breathing. So would you guys have any suggestions for this patient? Have you seen a patient like this one?
I think we've seen lots of patients like this one. And it is honestly, again, unfortunately, it's really hard to give a specific suggestion beyond just, maintaining. So I think the two things that come to mind are, one, in this population, when impairments are severe like this, kind of what are we hoping to improve? So, if it's specifically like swallowing physiology, that might not change very much. But if it's specifically, eating in public, burden, which is probably where the diaphragmatic breathing comes in, but like the symptom burden of feeling as though they can't breathe, things like that, just kind of, thinking about like, what is the reason that this person is here in front of me, regardless of some of the specific physiological impairments, but what's the impact and what's my role there? And then specific to lymphedema, I mean, if they're with a CLT, if they're getting like complete decongestive therapy, which I'm sure they are with a CLT, and then also therapy specific to swallowing with you, I mean, really, like, you can only do what you can do. And I think the only other thing I would say, without being the person to provide more education, is between you and the OT, don't be afraid to get inside their mouth.
So this next question here is for Julia. So did you train for full body lymphedema treatment or head and neck only? Can you kind of walk us through just your training, what all it entailed, and maybe if you would recommend it to other SLPs?
Sure. Yeah. So my first kind of exposure to kind of hands-on, and I guess also even backing up further, like speech pathology, I think traditionally, if you think about it, you're sitting across the table from somebody else. And I think that was how I started my career, was sitting across the table from someone else. And now really just feeling comfortable with like putting my hands on and in somebody's mouth, especially. But just being comfortable with I think that's just not a natural thing for speech pathologists to do. And so I guess my first exposure to that was through a conference where a like breakout session regarding head and neck lymphedema was done. Then I think, I went to another head and neck specific course. This was pre-COVID through ACLS, I think that's how you say it. And ironically, I was a day out from a biopsy, a post-treatment biopsy, because they thought that there was maybe some residual disease. So I was a little out of it at that class, but it was a head and neck specific class. And I did not feel like ready or prepared, not just because of the recent biopsy or procedure, but then through Norton is when I took the full lymphedema course, the full body, wrapped a bunch of legs and arms, knowing that I would never wrap another leg or arm again. And I would say that even though there was very limited head and neck specific content in that course, There was a ton of pre-course material to go through, really diving into like the lymphatic system and what is lymphedema. And then I actually will be taking a head and neck specific course in the fall. So I feel like this will be like my second head and neck specific lymphedema course, sandwiching a full-on certification course. So I just feel like over and over again, hearing the information in different ways at different time points has made it more salient as I've kind of gone through my professional career and seen more and more patients. So yeah, I do found it beneficial, and am excited to take the head and neck specific course this winter.
I just have a comment that is kind of how Julia kind of went full circle there, like starting with head and neck lymphedema course and then lots of other things, and then going back to a head and neck lymphedema course. I think I could also, I don't know, maybe use that as an analogy, I guess, to the concepts of physically touching people, the component of manual intervention, and the cross systems approach needed to really effectively treat these people. And kind of beginning with like, I don't know what I'm doing. Should I be doing this? To then understanding, which this part's very much my personal opinion, but understanding that all of the things that I'm doing, the exercises, the range of motion, the stretching, anything manual, it is, in my opinion, quite impossible to quote somebody else, singularly and selectively affect change upon one system and one system alone. So that then kind of puts me at ease a little bit with what I'm doing. But then when you start getting into it, full circle back to, I need to really know what I'm doing. I need to understand everything here.
So the next one is not a question, but it's an awesome comment. So she said, no question per se, but just wanted to say I really enjoyed this webinar. It touches on an area, mental health, that really isn't addressed as much as the physical side of post-cancer realm. She said, I'm so excited to see the resources, as so many of them address upper extremity and lower extremity, but we don't have as many resources for head and neck. So that's something, to with Tactile that we can really help just in terms of education for these patients and providers, just reassuring that patients aren't slipping through the cracks. So the next one is a question. So she said, how do you support patients who feel overwhelmed with complicated and multiple exercise programs? So symptoms and kind of keeping up with the nutrition. Any apps or programs to help manage so many things to do for these patients? Amber, is that something you would want to chime in on at all?
You're talking about exercise programs?
Or just, yeah.
So,
I
feel like Julia and I both absolutely love this question. It's a huge, I guess maybe soapbox, lots of things. But my first thought is there's a wealth of literature out there about adherence and patient adherence. And really maybe we could, how can we help somebody motivate to do what they need to do? I just got to notice my internet connection's unstable, so if I cut out. But one example I can think of specifically is just being creative with, there's a lot of exercise programs, and basically a lot of the different things that we do and give people, they are kind of working upon the same systems, but how can we combine things? I've had somebody doing their jaw program and their cervical range of motion exercises at the same time, for example. But just how do you, really make it more doable and more concise, because people can end up with a crazy amount of exercises. And then also be flexible with, what's most meaningful or most important to you today might change over time. And how can we not forget about other important things, but how do we work on what's the biggest problem for you right now? Is it, turning your head when you're driving, or is it opening your mouth to take a bite of a banana or whatever? And just kind of like knowing that there's going to be a constant change in how that home exercise program looks for them. Okay, I'm gonna let you.
I was completely agree. I feel like there have been times where, like I've sat down with a patient and they've just kind of like handed me all their stuff, whether it's from me or other providers, and they're like, and we just like go through it, and we're like, okay, what is the most important to address right now? What's the most salient thing to you in this moment? Let's kind of rank this, like hierarchy it, which is sometimes hard to do, but it can be done. And then also, I think Erin touched on that concept of like motivation and, I think when we position ourselves on the side of trying to maybe convince a patient to do something, they're going to then inherently kind of find the reasons not to do it. And so that's just a little bit in the realm of motivational interviewing, which I just really love as a topic. So there's lots of good reading out there about motivational interviewing and how to talk to your patients. Again, understanding that some of the things you mentioned, like diarrhea and stuff like that, like there are some like acute toxicities of treatment that are going to be really hard to overcome, and really for that patient to engage in therapy. Pain is another thing I'm thinking of. Like those things need to be managed maybe first and foremost before they're even in the right frame of mind to really engage in some of the things that you're wanting them to do.
To piggyback a little bit on what y'all are saying, it threw me about the exercises. I'm like, what? I would assess with your patient what other life stressors are going on. If they're saying that there's too much exercise or they don't know which to do first, that kind of stuff, I would also find out what else is going on in their personal lives, because that could be affecting what they are able logistically to be able to do with time management, family life, that's a work life.
I think this just perfectly highlights like where we as multidisciplinary team members have to lean on each other, even when you think it's not, maybe not something for the social worker, for example, like maybe it is, and maybe there's a conversation there that can be held. And then also just, again, how we are playing a role in their overall mental health. And adherence to exercise programs and behavioral change and motivational interviewing, those just by name, like those aren't things that are necessarily like out the gate, oh, as a speech therapist, you learn these things, but it's information and knowledge that I try to educate myself in and use within reason, and then also stay in communication with people like Amber.
I think bottom line, and keeping it really real, is just asking your patient questions. How is this affecting you? How can I help? What else is going on? Just having those questions and tell me how that feels. What's that like for you? Will open up a lot of doors and will lead you down the right path for your patient.
Okay, just one more question here. And I do feel like this is an important one. So in your practice or cancer center, who identified the need for therapy services such as CLT, SLP, and then also mental health? So that probably comes from somebody who is struggling to kind of, explain what that need is. So do you guys know how that worked at your cancer center?
So I would say that we tend to know about people very early on, especially because we see people all through the continuum. So I'm an inpatient and outpatient. Erin's primarily outpatient, but also helps with inpatient too. So it's like there are times in which I will see a patient we are around the clinician we're around the surgeons in clinic at the time that they're having an initial surgery consult, and they might say, hey, can you come in and talk to this patient? They're going to have surgery. And then at that point, like I know about them and I keep them on my radar, and I might see them pre-op consult in the hospital after their surgery. post-op consult, and then 6 weeks later they start radiation, and I know about them. And so some of the cases, it's more of like just being in and around the physicians who are providing the care in clinic with them, and not necessarily on an isolated rehab island, has opened up a lot of doors in terms of collaborating with the surgeons and physicians, and being in the know about who's coming down the pipeline. I guess I don't know if I covered that all, Erin, but
I mean,
Absolutely.
I think like there's a lot of different answers to that, but if I bring it all the way down to me and what can I do, I think, and here's a good, what I wish I would have known 5 years ago. This was something we were maybe tasked with and didn't really know how to answer for this talk, but you're going to need to show up places. You're going to need to stick your nose in places like within reason, but things that made the biggest impact for me over the past, let's say 13 years were being really uncomfortable, but walking myself into the radiation oncology clinic, physically being there, being in front of the nurses, forming a relationship with them, because we all know that the sooner the better that we get these referrals. So how does that happen and whose job that is? I feel like that conversation can't really come until we know all the players and we have relationships with them. And then Julia talked about just care cascades and
kind of that like entry, like depending on what provider sees them first, but it is standard for us for speech to see every head neck patient. Now, then I would say too, a vast majority of the providers are well versed in recognizing lymphedema or the need for lymphedema services. And so having that physician champion, I can think of one in particular who's really been paramount to that. So I would say that having a well-educated physicians goes a long way as well. But we are supposed to receive orders on every head and neck patient. And then sometimes, again, we're also connecting to care through Amber. I would say speech is often the first rehab group to see, or rehab discipline to see the head and neck patient. So it's really important that we're ready to kind of dish off services as we need. And we really rely on those outcome measures and interviews and deep medical chart dives to make sure that we connect to who they need to see.
Awesome. So this does wrap up our Q&A portion. I just want to thank the 4 panelists so much. You ladies did an outstanding job. And thank you so much to our participants who attended as well. If you have any follow-up questions, please feel free to reach out. And there are clapping hands coming across the screen. So thank you guys all so much and enjoy the rest of your evening.